Right, so we want to talk about the brainstem, right? Your brainstem is basically the stalk of the brain, right? So you have a midbrain, you have the pons, then you have the medulla. And remember, these parts, they're coming from the neural tube. Remember, your neural tube was going to form your primary vesicles. Then the primary vesicles were going to give you secondary vesicles. Remember, we had the forebrain, the midbrain, and the hindbrain. Of those three, the midbrain was the only one that remained as a primary vesicle. It didn't form a secondary vesicle. The appropriate name was mesencephalon. Mise meaning amongst or in between. So that's what forms the midbrain. Right. Then the telencephalon gave rise to the cerebral cortex as well as structures of the basal ganglia. Then we had something called diencephalon, which I'm sure will be our next talk after the brainstem, which gives rise to diencephalic structures. Then we had the rhombencephalon, or your hindbrain, which we divide into two. There was a metencephalon, then a mylencephalon. Metencephalon gives rise to the pons. This is the pons. It looks like a pregnant lady, so it's this bulge here. Then we have what we call the medulla, which is your myelencephalon, right? So contrary to common belief that people think with their medulla, remember like the song in some famous Zimbabwean whatever was saying that you need to use your medulla or what to think. This is the medulla that they were talking about, though it's not used to think. So medulla is what then transitions to spinal cord, right? So if you know the structure of the spinal cord, if you go to the medulla, the first part of the medulla, as you go up, they will resemble the spinal cord. So the same layout that you are having in the spinal cord will be the same layout that you're going to see in the medulla, right? Then lengthwise, this brainstem is about 7 centimeters, right? And of those 7 centimeters, the first 3 centimeters belong to the medulla. So the medulla is 3 centimeters. The pons is about 2.5 centimeters. Then the midbrain is about 1.5 centimeters. These are just average lengths. Of course, not everyone is the same, right? Right. So the first thing would be to look at the external features of the brainstem. By external features, we're referring to structures that you're going to be able to see from the outside. And what I want you guys more to remember would be your cranial nerves and where they are attached. But before we go to cranial nerves and where they are attached, we can generally give an outline to show the parts of the medulla, right? So this is the medulla, right? We say it's about 3 centimeters. This is the ventral aspect of the medulla, right? Remember when we use the word ventral and dorsal, for the brain, we are not referring to anterior and posterior, no. Ventral and dorsal, we are taking it from embryology where if you look at a developing baby, the undersurface becomes the ventral, then the top part becomes the dorsal, right? So we have a median sulcus, which we call the ventral median sulcus, right? On either side of this ventral median sulcus, we have these two bulges. These two bulges, we refer to them as the pyramids. So there is a ventral median sulcus, then you have two pyramids, right? Then after the pyramid, there is another sulcus. So a sulcus is just a small depression that is going to help you delineate these brain structures to say this is the pyramid, this is where the pyramid ends. Then I have another sulcus, which I call the ventrolateral sulcus. This ventrolateral sulcus will separate the pyramid from what we call the olive, right? So recap, we have a median sulcus. Then on either side of your median sulcus, you have the pyramids, right? Then on either side of the pyramids, you have a ventrolateral sulcus, which then separates your pyramid from the olive, right? Then the cranial nerves that exit on the medulla. Remember, you had a neck, we said we had 12 cranial nerves, 1 to 12. If you want to add the cranial nerve 0, you say 13, but let's just say 12. So the last 4 cranial nerves, which is cranial nerve number 9, 10, 11, and 12, they come off the medulla, right? So before I say anything, I want you guys to remember this. When you're doing the spinal cord, we say that motor was anterior, sensory was posterior. Then I say that as you develop the brainstem, it flares out such that motor becomes medial, sensory becomes lateral. So when you look at this, the hypoglossal nerve, which is a purely motor nerve for muscles of the tongue, it exits between the pyramid and the olive. So here you can appreciate the rootlets of the hypoglossal nerve. There'll be about 5 to 6 in number. Then they join to give you that hypoglossal nerve, right? Then that's a purely motor nerve, so it's medial. So even when I then show you the internal features of the medulla, you're going to see that the motor nuclei are medial. Those that are mixed will follow. Then those that are purely sensory will be lateral. Right? So just take it like it's a spinal cord that has been opened. So if you open something, what used to be posterior is going to be very lateral. Then what used to be anterior will just be medial. Right? That's what you guys should use to remember. So we said the last 4 cranial nerves are on the medulla. So cranial nerve number 12 is between the pyramid and the olive. Then cranial nerve number 9, number 10, and number 11, they are between the olive and what's on the outer surface of the olive, which is the inferior cerebellar peduncle. So something that I should have told you from the start is each part of the brainstem is connected to the cerebellum by a cerebellar peduncle. So remember, we have 3 parts of the brainstem: the midbrain, the pons, then the medulla. So the midbrain is connected to the cerebellum via a superior cerebellar peduncle. The pons is connected to the cerebellum via a middle cerebellar peduncle. The medulla is connected to the cerebellum via an inferior cerebellar peduncle. So what I was saying is that between the olive and the inferior cerebellar peduncle, that's where you find cranial nerves number 9, number 10, and number 11. But between the pyramid and the olive, that's where you find number 12. When you then do the internal features, you're going to find that those cranial nerves that I said are on the outside, which is 9, 10, and 11, they're going to originate from the nucleus ambiguous. It's called ambiguous because remember the word ambiguous, it's neither there nor there, right? So it's going to give rise to more than one cranial nerve. And remember that those cranial nerves, if you trace them back to the head and neck, they form the pharyngeal plexus. Then you remember the innervate things in the palate, the pharynx, the what, they move together, right? Then after medulla, we have pons. So notice there is a junction between the pons and the medulla, which we call the ponto-medullary junction. At that ponto-medullary junction, there is cranial nerve 6, 7, 8. If you remember the cranial foramina in your head and neck skull anatomy, we numbered these cranial nerves in order. The first was 1, the second was 2, third was third. Right? So it's the same here. As you go up, of course, the normal thing which I'm used to teaching would have been coming from up going down, but we are coming from below going up. So that's why we started with 12. So pontomedullary junction, there is 6 abducens, 7 the facial, and 8 the vestibulocochlear. And remember what I said, the motor are going to be medial, then the sensory are going to be lateral. So already you know that vestibulocochlear is for the ear, it's going to be for hearing and balance. All those are sensations. So that's going to be the most lateral of those 3. Number 6, abducens, it's a purely motor nerve. You remember it innervates the lateral rectus of the eye only. So that's going to be more medial. But the facial nerve, remember it innervates muscles of facial expression. That's going to carry taste fibers from your anterior 2/3 via the chorda tympani. It gives you a greater petrosal nerve, greater petrosal nerve for lacrimal gland, lacrimation, whatever. And there's some form of sensory as well to the ear. So that's going to be a mixed nerve. So it's kind of in the middle, right? So far we've said 6, 7, 8. So 7, as it exits the brainstem, there are 2 routes, right? One is a sensory route, one is a medial route. Is a motor route rather, and that motor route is medial. The motor route is medial because I said motor is medial. The sensory, which is called nervus intermedius, we call it intermedius because it lies between the motor route and the vestibulocochlear. So it's somewhere in between. Right? So just remember that the facial nerve exits by 2 routes. We'll mention that again as we do the internal features. Then this is the pons, which is your pregnant lady. Remember I said it's about 2.5 centimeters. It has a basilar sulcus here, where you expect to find an artery called the basilar artery. Basilar artery is formed from the union of the vertebral arteries. Your vertebral arteries are coming off the first part of your subclavian arteries, if you remember your thorax anatomy. Right? So vertebral artery is the one that is going to give us the posterior circulation of the brain. The 2 vertebrals will join to form a basilar artery. Where do I find the basilar artery? The basilar artery lies in this basilar sulcus, right? Then there is one nerve that comes off directly from the pons. It is this nerve here, the trigeminal nerve, right? So the trigeminal nerve, that's cranial nerve number 5. It's a mixed nerve. It is motor and sensory. Remember, it gave us V1, V2, which is ophthalmic, and maxillary, respectively, which were purely sensory. Then V3, which was your mandibular, which was mixed because it had sensory and motor. Right. So this trigeminal nerve, where it exits on the pons, is where the pons actually ends on this lateral side. So everything that you're seeing on the sides here, after the trigeminal nerve, this is no longer the pons. This is now the medu cerebellar peduncle. Remember I said each portion of the brainstem is going to have a cerebellar peduncle that connects it to the cerebellum. Right. Then up here we get the midbrain. Midbrain is going to have 2 cranial nerves. But of those cranial nerves, I just want you to remember that it's cranial nerve number 3, your oculomotor. Then cranial nerve number 4, the trochlea. But remember I said this is the ventral aspect. The trochlea is the only cranial nerve that exits the brainstem on the dorsal aspect, right? So trochlear nerve here, you can see from the back. This is the trochlear nerve here. took these pictures from a book called Buzz Neuroanatomy. Right. So this is the trochlear nerve, is the only one that exits from the back. Right. This is now just a picture that's showing us your actual brain. So here we have medulla. Here we have the pons. Then up there you expect the midbrain. Then this is the optic nerve and its chiasma. Right. Then here are some of the nerves. This is pontomedullary junction. Remember I said cranial nerve number 6, then number 7, then number 8. Then after this is medulla. This is the pyramid. After the pyramid, we said we see hypoglossal nerve. Then you have the olive. Then between olive and inferior cerebellar peduncle, you see everything else. Right. Right. This is the back of the brainstem. From the back here, I want you to appreciate a couple of things. I have something called the dorsal median sulcus here. So dorsal median sulcus. On either side of the dorsal median sulcus, I have the gracile fasciculus. Right? Then on either side of the gracile fasciculus, there is the cuneate fasciculus. So gracile fasciculus and cuneate fasciculus. Remember when we were doing your what do we call this? Your spinal cord. We talked about the dorsal columns where we had the fasciculus gracilis and cuneatus, which were carrying the fine touch, the proprioception, the vibrations. So those sensations or those parts of the spinal cord, they continue onto the brainstem. Right? And when we do the internal features of the brainstem, you're going to find that the nuclei, which is the nucleus gracilis and the nucleus cuneatus, are actually in the medulla. Right? Then on the lateral aspect of this cuneate fasciculus, on the outside here, the third bundle here, we call it the tuberculum cinereum. Right? This tuberculum cinereum is different from something called the tuber cinereum. Tuber cinereum, we'll discuss it as we do the region around the optic chiasma. But this tuberculum cinereum, it's as a result of the underlying spinal trigeminal tract and its nucleus. So the spinal trigeminal tract and its nucleus, these are part of the, so remember each cranial nerve has a nucleus, at least one nucleus, but the trigeminal nerve is unique in that it is the only cranial nerve that has a nucleus in every portion of the brainstem. So there's a nucleus in the midbrain, a nucleus in the pons, and a nucleus in the medulla. The nucleus in the medulla is what we call the spinal trigeminal nucleus. It is responsible for this bulge, which we call the tuberculum cinereum. The spinal trigeminal, we usually equate it to Rex lamina number, the one for pain, because this tuberculum, this spinal trigeminal nuclei, they are basically going to be carrying pain sensations of the head and neck. Remember, the trigeminal was the sensory of the face, the head and neck. So also we expect pain there, right? Then this darkish shaped region here, I would want you to remember this thing. It's a very important region, right? The apex of the V here is what we call the orbix, right? Then these things, I think you can look them up. They're on the other video, how we divide it into a medial eminence as a result of the facial. We'll do this as we do the nuclei, because it simply just explains positions of nuclei within the brainstem on the inside. There's a bulge for the facial nucleus. There's a bulge for the hypoglossal nucleus. Yeah, the hypoglossal trigone. There's a bulge for the dorsal vagal nucleus, which is creating this vagal trigone. Right. Then there are these fibers that are crossing, which we call the stria medullaris. I'll give reference to this. For now, I just want you to know that there's a stria medullaris here. But when I then do the internal features, I'll give reference to these fibers because these are actually fibers that are crossing to go to the cerebellum of the opposite side. Right? I'll give reference to this when I do the internal features. Right. There's a picture that I included to show this region, the V that I was trying to talk about. It's almost rhomboid shaped. And remember, that's where the fourth ventricle will be. Right. And I also want you to know that the area postrema is there. Yeah. Remember the vomiting centers? I'm sure you've done your GIT physiology. Your vomiting centers are also there. Right. So this is the flow of the fourth ventricle. Right. So that region that I was showing you, it simply shows the flow of the fourth ventricle. Right. The roof, of course, in a live brain, the cerebellum will be sitting on top there. So you can't expect to see the V. Right. So those are more or less your external features for the cerebellum. So I'm seeing a question. Is there a question in the chat? Stria medullaris is white matter that connects the hypothalamus to the habenula. Anyway, you're not wrong to say that, but in this case, you're wrong. Right.
Why?
Why? What connects the hypothalamus to habenula?
My Dr. G.
What connects hypothalamus to the habenula?
I want a stria medullaris. I'm not so sure.
Okay, but okay, you're not wrong. You're not wrong, but in this case, you're wrong. We'll discuss this with internal features.
Okay.
Right. Okay. What did I want to do next? Anyway, because I'm saying I'll have like 13 minutes, but anyway, I'll just tell you. Okay, let me just tell you. Remember I said the other time I told you that the cerebellum controls the same side of the body. You remember me saying that, right? So this medullary stria, which you are trying to, the other one is actually called stria medullaris thalami, right? This is just a medullary stria. So when we look at the inside, we're going to see what we call the cochlear nuclei, right? So fibers that are going to, some of the fibers that are vestibulocochlear, some of the fibers that are going to be concerned with balance, they're going to have to decassette to the other side of the cerebellum via this stria medullae. It's not really the same as thinking about your, what do you call it? Your stria medullae thalami. It's really different. Right? But anyway, I'll introduce internal features. So I know you guys have watched the videos on internal features of the brainstem. It's a lot. Where do you want me to touch on first? Because medulla, you look at it from three different levels. level of decussation of the pyramids, then level of the medial lemniscus, where there is decussation of the sensory pathway, your dorsal column medial lemniscus pathway, then level of the olive, which is basically the upper part of the medulla, where you expect some of the fibers to exit via the cerebellar peduncle to go to your cerebellum. Then we go to people then talk about the pons. Pons, we use two levels, the lower part and the upper part. When you go to midbrain, we use two levels, which is level of the inferior colliculus and level of the superior colliculus, right? What I think is more important is not for you to cram positions of nuclei, but rather would be to know the syndromes that are associated with each part of the brainstem, and as well as the blood supply. But blood supply, neither there nor there. This is something we can do in a separate talk. But the reason why I included these slides on the blood supply is that some of the clinicals that we see are as a result of infarcts in these arteries, right? So I want to bring your attention to the medulla in terms of clinicals. So there are two syndromes, main syndromes. There is the medial medullary syndrome, then there's the lateral medullary syndrome. So what happens in medial medullary syndrome is there's an infarct in the region that is supplied by the anterior spinal artery. So what happens is you affect structures in the medulla that are medial. When you look at the lateral medullary syndrome, you affect structures that are lateral. The artery more affected there is your pica, your posterior inferior cerebellar artery, right? So remember I said the hypoglossal nucleus is in the medulla. And it being a purely motor nucleus, it's going to be medial. So the medial medullary syndrome will affect the hypoglossal nucleus, right? So you have paralysis of the tongue on the same side. So if I get the problem on the right, I have paralysis of the tongue on the right. Then the pyramids are in that region. Right. So remember, the pyramid is where the corticospinal fibers, 85% of your corticospinal fibers decussate. So as they are decussating, right, they can be affected. So you can get a hemiplegia on the contralateral side. I'm getting the infarct on the right brainstem, but the problems will be seen on the left body because the fibers that were on the right brainstem that I've affected, they're supposed to decussate and come to the left. So I get a contralateral hemiplegia. Right? But in terms of things like fine touch and what, those things, remember the decussation for your dorsal column medial lemniscus, it's somewhere higher up in the medulla. So when I get a lesion, I'm affecting fibers that have not yet decussated. Right? So you can have the symptoms limited to that side. Or if you affect the medial lemniscus, as is in most cases, the medial lemniscus, the things would have decussated. So you're going to have loss of touch and fine touch, proprioception, vibration on the opposite side. Right. Wallenberg is lateral medullary syndrome. Right. What do I use to remember this? I'll just remember the nucleus ambiguous. Remember I said nucleus ambiguous will feed 9, 10, 11. So I'll just think about what those cranial nerves do in the head and neck. The pharynx, the palate, the uvula, right? So the uvula deviates to the opposite side. So you get ipsilateral signs, then you get contralateral signs. So let's say I affect the right side. Cranial nerves usually don't decussate much. So I'm going to lose pain and temperature on the right side because remember, on the lateral aspect, I said that tuberculum cinereum was as a result of the spinal trigeminal nucleus. The spinal trigeminal nucleus is for pain and temperature for the head and neck. So you're going to lose those on the same side. Then on that lateral side, there's a fiber or there's a band of fibers that travels there, which people don't really talk about, which is the hypothalamus spinal. Right? Hypothalamus spinal carries sympathetic and parasympathetic to the spinal cord. So you get a Horner's syndrome. I'm sure everyone knows Horner's syndrome. It's not really three things, it's four things. Most people think it's three. There's three eye signs and one cutaneous sign. The three eye signs, you have ptosis, which is drooping of the upper eyelid as a result of weakness of the molar muscle, which gets sympathetic innervation. It's different from the ptosis from oculomotor nerve palsy, where there is weakness of the levator palpebrae superioris. Then there's meiosis. Meiosis, it's you get it since the sympathetic. Remember, sympathetic, when you want to see when you see a line, you want to see as far as possible. You want to run, so you dilate your pupil. So if you lose sympathetic to the eye, you have unopposed parasympathetic, so it constricts greatly. That's meiosis. Then the other one is enophthalmosis, though not written there. Then anhidrosis is the cutaneous sign where you lose sweating, right? Then just remember as well that the uvula will deviate. Remember the uvula, if you open your mouth, you see the uvula sitting right at the back, between your pillars and the mouth, right? So you're going to get an uvula deviation, right? Then there is difficulty in swallowing, dysphagia. So dysphagia also has neurological causes. Right? This goes back to say it's a general symptom, yes, but your phases of swallowing. Remember, you have about 3 phases of swallowing from your physiology of phases of deglutition. You have the oral phase, then I think there's a pharyngeal phase, then the last phase. So those things will be affected. That's how they get dysphagia. Right. Vertigo and nystagmus, what we call dzungu in Shona. This is because you affect the vestibular nuclei in the medulla. So you also have vestibular nuclei, right? Syndromes for the pons. I wouldn't want to bore you with this because it's not really expected for you guys to know. They're actually journals that dispute what's in the books. What's the difference between Millard Kubler, Fourville, and even the midbrain ones, your Weber syndrome, what. But this one I would want you to know, Perinaud. Perinaud syndrome is you see it in a lot of cases. So whenever you get compression of the tectum of the midbrain, or basically the midbrain, the dorsal part of the midbrain, you get Perinaud syndrome. So Perinaud syndrome is a syndrome because a syndrome, remember, it's a constellation of 3 or more symptoms, right? So when you get your hydrocephalus babies, remember the hydrocephalus where CSF is not moving. We're going to talk about that when we do the ventricles. You get an increase in intracranial pressure. So that compresses on the back of the midbrain, and they get this Perinaud dorsal midbrain syndrome. What you see on the outside, if you've ever seen a baby that is that like a sign that we call sunsetting eyes, it's like the black of their eye is sinking inward. And that's what most people know. It's a part of Perinaud syndrome. It's explained by this Perinaud syndrome. So I just want you to know that Perinaud syndrome is as a result of compression of the dorsal midbrain. Of course, here it's talking about in children, aqueduct stenosis. Aqueduct stenosis will cause hydrocephalus because you block the aqueduct, so CSF remains in the third ventricle and the lateral ventricles. There's a buildup of intracranial pressure. A pinealoma, which is a pineal gland tumor, can also compress on the midbrain. We'll do the pineal gland as we do the diencephalon, right? So this slide, I made this slide in 2021. I was presenting to people who were doing a degree in anatomy, not medical students. So that's why I'm skipping some of the other things. Like, I know this I talked about in the other videos. I would want you to know like the representation of the body in the midbrain. When you look at this, at these fibers, that the head is medial, the leg is lateral. Of course, this would be important for medical students so that we can be able to, locate lesions, right? So the things that are important, which I'm sure we can talk about in the second session. Then, like the internal features of the brainstem. So we can now start to talk about at this level. You see this is important. This you can skip because you can never know everything, right? So I'm sure I'm running out